Welcome to the deep dive. Let's kick things off with a statistic that's, well, it's quite sobering, actually. In Singapore, we see almost 5 amputations every single day in patients with diabetes mellitus.
5 a day.
Yeah,
That's a lot.
it is. And what's really striking is that, many of these could potentially be avoided.
With the right care, the right assessment. Yeah.
Exactly. Which brings us to our topic for this session. We're doing a deep dive into something absolutely vital for you, our family medicine residents: foot assessment in patients with diabetes.
It's a really critical area.
We'll be pulling from the latest ACE clinical guidance. That's the Foot Assessment in Patients with Diabetes Mellitus-OG 2024.pdf. And also weaving in some practical insights from the Screening for Diabetes in Primary Care.md OSCE station material. Stuff that's, really tailored for primary care right here in Singapore.
Yeah, those two sources complement each other really well, don't they? You've got the evidence-based framework from ACE, and then the practical application, how it looks in the clinic, from the OSCE material.
Spot on. And to really bring this to life for you, we thought we'd walk through a role play, a typical kind of consultation you might have.
Oh, good idea.
Yeah.
That always helps connect the dots, I find, between the guidelines and, the actual patient sitting in front of you.
Okay, so picture this. You're the family medicine resident, you're in your clinic room, could be a polyclinic, could be a GP clinic, and your next patient walks in, family medicine resident. Good morning, Mr. Tan. Please come in, have a seat. I see you're here for a routine checkup today, Mr. John Tan. Yes, doctor, thank you. Morning, family medicine resident. So how have you been feeling generally? Is there anything specific, any concerns bringing you in today, Mr. John Tan? Well, I've been feeling okay, I suppose. Nothing really major, but I am a bit worried, doctor. You see, my mother, she has type 2 diabetes.
Yeah.
Family medicine resident. Okay, Mr. John Tan. And I've read things that it can run in families. So I was hoping maybe I could get screened for it today. Family medicine resident. I understand that's a very valid concern, Mr. Tan, especially with family history like that. It's definitely sensible to look into it. Maybe tell me a bit more about your daily routine. What's a typical day like for you, Mr. John Tan?
Well, I work in an office
Yeah.
manager, so it's mostly sitting, at a desk. I drive to work, exercise.
Not really much during the week, I have to admit. Maybe a short walk on the weekend if I get the chance. Family medicine resident. Okay, sedentary work, driving. Got it. And what about your diet? What sort of things do you typically eat, Mr. John Tan? Well, probably not the best, if I'm being honest. Lunch is usually, quick and easy at the hawker center. Char kway teow, maybe chicken rice, nasi lemak, that kind of thing. Family medicine resident. Right, the usual suspects. Mr. John Tan, yeah. Dinner can be similar sometimes. I try to have fruit sometimes, but vegetables, probably not enough. Oh, and I take my coffee or tea with sugar every day, but not really sugary soft drinks. Not much anyway. Family medicine resident. Okay. And any alcohol? Smoking. Mr. John Tan, oh, no smoking. Definitely not. Alcohol, maybe a couple of beers sometimes on the weekend if I'm out with friends socially. Family medicine resident. Okay, thanks for sharing that, Mr. Pan. You mentioned your mother has type 2 diabetes. Do you know roughly when she was diagnosed or if she's had any complications from it, Mr. John Tan? Let me think. She was probably in her late 50s. Maybe early 60s. And yeah, she's had some trouble with her eyes recently. That's part of why I'm worried. Family medicine resident. Understandable, Mr. John Tan. And my father, he has high blood pressure. Had a heart attack a few years back too. So yeah, family medicine resident. I see. So it sounds like you're quite rightly concerned about, potentially developing diabetes yourself and maybe facing similar health issues down the line. Is that fair to say? Mr. John Tan. Yes, exactly, doctor. That's it. And I'm also a bit anxious about having to make big changes, especially my food, Giving up my favorite hawker food sounds tough. Family medicine resident. No, I understand that completely. It's natural to feel that way. And thinking about today's visit, what were you hoping we could achieve? What were your expectations? Mr. John Tan, well, I guess I was hoping you could tell me, what's my risk? Is it high? And should I do a blood test? Family medicine resident. Okay, Mr. John Tan. And, maybe some advice on what I can actually do to lower the risk, maybe. Family medicine resident. Absolutely, Mr. Tan. We can definitely cover all of that. Let's look at some of the measurements we took earlier. Your blood pressure is 138/85. Mr. John Tan. Family medicine resident. Your body mass index, your BMI, it's 28. And your waist circumference is 102 centimeters.
Okay, so even just those numbers start painting a picture, don't they, for his risk profile?
They really do. And it's so important here, especially for you listening, to remember those Asian-specific cutoffs. BMI, 23 or more is overweight, and 27.5 or higher is obese. So Mr. Tan at 28.
He's in the obese category for our population. Yeah.
Exactly.
And the waist circumference, too, that 102 centimeters. For Asian men, anything 90 centimeters or above points towards central adiposity. That's a big risk factor for insulin resistance, diabetes, heart disease.
Right. He's well over that threshold. Family medicine resident. So, Mr. Tan, taking everything together, your family history, your BMI being 28, that waist measurement of 102 centimeters, your largely sedentary lifestyle, and a diet that sounds like it's often high in refined carbohydrates and sugars, which, yes, is common with some popular hawker choices. Mr. John Tan. Yeah. Family medicine resident. It does suggest you have an elevated risk of developing diabetes. Your blood pressure is also a little on the high side, which adds to that overall picture, Mrs. John Tan. So, it is quite high then, my risk, family medicine resident. It's certainly higher than average, yes. And because of this risk profile, the current guidelines definitely recommend we do a screening test for diabetes. We've got a couple of main options. Both are blood tests, Mr. John Tan. Okay. Family medicine resident. One is called a fasting plasma glucose, or FPG. For that one, you need to fast nothing to eat or drink except water for at least 8 hours beforehand. It tells us your blood sugar level at that specific moment. Mr. John Tan. Right. Fasting. Family medicine resident. The other main option is a test called HbA1c. That stands for glycated hemoglobin. This one's quite convenient because you don't need to fast. It gives us an idea of your average blood sugar levels over the last 2 to 3 months. Mr. John Tan. Oh, okay. No fasting sounds easier. Family medicine resident. It often is. Both tests are perfectly suitable for screening in your situation. The HbA1c gives that longer-term picture, while the FPG can sometimes pick up earlier changes. We could do either, or sometimes both are done. What are you leaning towards, Mr. John Tan? I think the HbA1c sounds better for me. That's all right. The one without fasting, family medicine resident. Of course, we can certainly arrange the HbA1c test for you today. Now, while we wait for those results, it's also a really good time to talk about some lifestyle things. You mentioned enjoying local food. That's great. It's not usually about cutting things out completely. Mr. John Tan. Oh, good. Family medicine resident. It's more about making, slightly healthier choices within that. Maybe asking for less skin on the chicken rice or more vegetables on the side. Or with char kway teow, looking for stalls that use maybe more bean sprouts, less oil. Small swaps.
That's such a key point. Practical, sustainable advice. Family medicine resident. Exactly. And increasing fruits and vegetables generally, maybe cutting back a bit on the sugar in your coffee or tea. Those things add up. Mr. John Tan. Okay. Yeah, I suppose I could try that. Sounds less scary than I thought. Family medicine resident. Good. And the other piece is physical activity. We talked about your sedentary job. Even just aiming for, say, 30 minutes of brisk walking most days can make a huge difference, maybe during your lunch break or after work. Mr. John Tan. Yeah, maybe I could fit in more walking. I could try. Family medicine resident. That would be a fantastic start. So the plan is we'll get the HbA1c test done. Once the results are back, usually in a few days, we'll arrange a follow-up appointment. We'll sit down, go through the results properly. Mr. John Tan. Okay. Family medicine resident, if everything's normal, fantastic. We'll talk about when to screen again and keep encouraging the healthy lifestyle. If the results show prediabetes or diabetes, we'll discuss the next steps that might involve more specific dietary advice, maybe a structured exercise plan, and sometimes medication might be considered. How does that plan sound to you, Mr. John Tan? That sounds very clear, doctor. Yes, that's good. Thank you for explaining it all. Family medicine resident, you're most welcome, Mr. Tan. We're here to help you with this. If any questions pop up before your next appointment, please just give us a call.
Okay, great. So that role play, while concise, it really touched on those key steps, didn't it? The history taking, interpreting the numbers.
Yeah, using those Asian cutoffs, explaining why screening is needed, the test options, and that initial crucial bit of lifestyle counseling. Very nicely done.
Right. So now let's pivot a bit. Let's use that as our foundation and dive into the ACE clinical guidance, specifically focusing on foot assessment. This is something that maybe doesn't get the spotlight in that initial screening chat, but wow, is it critical long term?
Absolutely critical. And the guidelines hit you with that statistic right away.
Yeah.
Almost 5 amputations a day here.
Yeah.
And 85% of them are preceded by a diabetic foot ulcer, a DFU.
That number, 85%, it really hammers home why this matters. It's a massive call to action, isn't it?
It really is. It tells us that regular, proper foot assessment isn't just, nice to have. It's fundamental diabetes care. It's about preventing life-changing complications.
Definitely. And the ACE guidelines are very clear on where to start. Recommendation 1 basically says, first things first, check for active diabetic foot conditions before you even think about long-term risk.
Right. Are we dealing with an emergency right now?
Exactly. Things like infection, signs of acute Charcot neuroosteoarthropathy, which Just for clarity for everyone listening, that's that serious condition where bones and joints in the foot break down because of nerve damage.
A major complication.
Or limb ischemia, where the blood flow is severely compromised. Figure 1 in the guidelines actually gives you clear pathways for these urgent situations. You need to know when to send someone straight to A&E or get an urgent specialist referral.
That initial check is non-negotiable, really.
Yeah.
You can't assess future risk properly if there's a fire burning right now, so to speak.
Well put. So, assuming there are no active urgent conditions, then we move to recommendation 2. This is all about assessing that individual patient's risk of developing a DFU down the track and putting them into a risk category.
And that stratification is key because it tells you how often you need to formally review their feet and who needs referring on to podiatry or other specialists.
And figure 2 in the guidance is your friend here. It lists out the risk factors really clearly. Things like, have they had an ulcer or amputation before? What's their kidney function, like that EGFR?
Yeah, EGFR 15 is a big one.
Calluses, foot deformities, any signs of peripheral arterial disease, PAD, that's the poor circulation.
Neuropathy, nerve damage.
Skin or nail problems, even just, practical things like whether the patient can actually see or reach their own feet to care for them.
Right. And based on how many of these factors are present and how severe they are, you categorize them. Low, moderate, or high risk.
And it's important for you, as residents, to get comfortable recognizing these. A thick callus needing regular shaving might push someone into moderate risk. Early PID signs, early neuropathy, moderate risk. Multiple factors. That bumps them up to high.
It's a cumulative picture.
Exactly. And the review frequency follows directly from that risk level. Low risk. You need to do a full foot check at least once a year.
Moderate risk. Bring them back every 6 months for review.
And high-risk patients, they need checking much more often, every 3 to 4 months. And those checks should really focus on the specific problems that put them in that high-risk category.
Makes sense. Keep a closer eye on the bigger problems.
The guidelines also remind us, though, that while these foot-specific risks determine the category, we still need to manage the whole patient, their blood sugar control, smoking status, their general foot care habits. It all plays a part.
Which leads perfectly into recommendation 3, doesn't it? Patient education.
Yes, so crucial. The guidelines stress educating all patients with diabetes regularly about lifestyle, why foot checks matter, how to do self-care, and choosing the right shoes, all aimed at cutting down that DFU risk.
And Figure 4 in the ACE document is a great resource for this, a visual guide you can use with patients.
What are the key messages we need to get across? Things like, check your feet every single day. Look for cuts, blisters, redness, swelling, any changes.
Wash and dry them properly every day, especially between the toes.
Careful nail care, maybe filing instead of clipping if vision or dexterity is poor. Moisturize the skin, but not between the toes, right? To avoid fungal infections.
Absolutely. And footwear is huge. Wear well-fitting shoes, covered shoes, good support. No walking barefoot, not even indoors.
Critically important, that one. And finally, stressing that they need to seek help early if they spot any wound or anything unusual. Don't wait.
Yeah, wait and see is not the approach for a diabetic foot issue.
Definitely not. And, thinking back to Mr. Tan in our role play, even if his tests come back normal now, he still has risk factors if he does develop diabetes later.
This whole foot assessment pathway becomes absolutely essential for him, part of his routine care.
Exactly. So, wrapping up the discussion part, what are the absolute key clinical pearls, the main takeaways for our family medicine residents listening?
Okay, number 1, always check for active foot problems first. Infection, Charcot, ischemia. Rule those out or manage them urgently.
Right.
Number 2, do a thorough risk assessment for DFU on all your diabetic patients at least annually. Use those ACE guideline factors, previous ulcer, PAD, neuropathy, deformity, etc., to stratify them properly into low, moderate, or high risk.
Got it. What's next?
Number 3, know when to refer. The guidelines give specifics: painful deformities, suspected Charcot, worrying PA times, bad neuropathy, pre-ulcers, nasty nails. Know your local pathways and refer appropriately to podiatry or specialists.
Okay. Crucial. And the last one.
And finally, maybe the most impactful day-to-day, empower your patients, educate them consistently about self-care, checking their feet daily, proper hygiene, good footwear, give them the tools to protect themselves.
Fantastic summary. It really underscores that regular, thorough foot assessment is just fundamental in preventing ulcers and amputations. Understanding risk, knowing when to refer, and patient education. Those are the pillars.
It really shows the power of primary care, doesn't it? That proactive, preventative role. We're not just managing blood sugar, we're actively preventing these really devastating complications through good assessment and education.
Absolutely. So for all of you listening, our strong encouragement is make comprehensive foot assessment a non-negotiable part of your routine care for every patient with diabetes. Really get to know the ACE guidance, understand your local referral options. It's time well spent, and it can genuinely change lives.
And maybe just a final thought to leave you with. How can you, in your busy clinic, make that patient education part really effective and consistent? Are there simple visual aids you could use? How do you make the advice practical and culturally relevant for your patients here in Singapore? Something to mull over.